Good.
All right, thank you. Good afternoon and welcome to the Insurance and Pharmaceutical Subcommittee of the Health and Government Operations Committee. Thank you for your patience and indulgence in our flexibility during this week before crossover. We have a number of bills on the agenda for today. I'm going to set some parameters. We will need to meet tomorrow, but so anything that is not already worked out, we are probably going to have to hold until tomorrow. But please understand that the closer we get to, or by 5 o'clock tomorrow, then we're going to be waiting until after crossover. So in order to, we want to make sure that we can get the bills ready to go to the extent possible before crossover. And I want to start today with House Bill 926, which is healthcare malpractice claims, healthcare provider definition. And that is Delegate Williams. But there was an amendment offered after yesterday's discussion. Aaron, you want to tell us about the bill and the amendment? Only you have to go unmute yourself.
The bill expands the definition of healthcare provider under Title III, Subtitle 2A of the Courts and Judicial Proceedings article, which governs the healthcare malpractice claims, to include an employee, agent, or contractor of a hospital who is licensed, certified, registered, or otherwise authorized to render healthcare services in Maryland. The amendments that were discussed yesterday kind of narrow the universe of individuals who would meet the definition of healthcare provider, to clarify that they are employees, agents, contractors of a hospital who is licensed, certified, registered, or authorized to provide healthcare services as defined in Section 19132H of the Health General article. There was discussion that to just make it limited to 19132H1 of the Health General article and not to H2, which had to do with dispensing.
Dispensing medical devices.
So it kind of limited it to make sure that it was just about people who are individuals who are providing healthcare services.
Okay.
So that is the amendment that Delegate Williams has wanted to present today.
Okay, thank you.
I'll move the amendment if you're ready.
I'll second it.
Okay, so I have a motion and a second on the amendment, and then I saw Delegate Taveras' hand.
And I just wanted to make sure that that excluded also like manufacturing.
Yes, it would.
It's
Okay.
practitioners.
Okay. Any discussion on this amendment? Seeing none, I have a motion and a second on the amendment. Those in favor of the amendment, please say aye.
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 Anyone opposed to the amendment? Seeing none, the amendment passes unanimously.
I'll move the bill as amended.
Second.
Okay, we have a motion on the bill as amended. Is there any discussion or questions on the motion on the bill as amended? Delegate Shalega.
Thanks, Madam Chair. Is the Hospital Association on? Jake, what can you tell us?
What was the question? I'm sorry, Delegate.
What is your position on the bill now?
We're favorable.
Okay, thank you.
Okay, any further questions or discussion? Seeing none, I will ask those who are in favor, please say aye.
Aye.
Is there any opposition to the bill as amended? Seeing none, the bill as amended passes unanimously. I want to thank you all for the great discussion that we had yesterday to get us to this point. Okay, I'm going to go to House Bill 859. Is Delegate Solomon here?
His staff is. I can quickly get him on if you'd like me to.
Okay, I would, because I'm going to try to take folks who are not on the committee.
Okay.
House Bill 859.
I believe they're both there. I see two different Solomons. I see Eden Durbin and then Delegate Jared Solomon. They should both be there. They're just not on the.
Okay.
Sorry,
Well,
Madam
his-
Chair, I was literally on my way down to committee, so I just popped into an office. Happy to answer any questions if anybody has them. Thank you.
Well, I'm going to introduce the bill first. Access to health insurance for childcare professionals, outreach and qualifying nonprofit satellite organizations. Delegate Solomon. Lisa, tell us what the bill does.
As
Yes.
introduced, the bill required the Maryland State Department of Education in collaboration with the Maryland Health Benefit Exchange to promote access to health insurance for child care professionals. The bill also expanded the definition of qualifying nonprofit organization and it did a few other things that are struck with the amendments. The amendments also provide that rather than the Department of Education in collaboration with the Maryland Health Benefit Exchange, that the Health Benefit Exchange will be the one to promote the access to health insurance, and that the amendments specify what resources will be provided, and they require a survey to assess current levels of healthcare access by childcare professionals.
Okay, Delegate Solomon, you want to speak to your amendments and how you came to this place?
Yeah, thank you, Madam Chair. First of all, I want to thank Committee Counsel and the Amendment Office for helping us with this. So I think as you all will remember, the original bill as drafted included what we had attempted to try to figure out a way through the qualifying nonprofit provision in state law to see if there was a way we could include certain types of childcare providers, give them the option to enroll on the state plan. We've had a lot of conversations with DBM, and we just don't think that's feasible at this point. So essentially, we struck everything that was in there, and we strengthened some of the outreach provisions, and worked really closely with the Benefits Exchange, who's more than happy to do this work. And I think the most important thing to share with you all is we've now shifted about $250,000 in the budget. The governor had proposed an additional $2 million into a Department of Commerce revolving loan fund for childcare capital expenses that we created in 2022, and they added another $2 million into this year's budget. So we're taking $250,000 of their $2 million, so they still have $1.75 million into that fund in addition, and they're comfortable with the money that we've taken to do this work. And the Benefits Exchange is happy to do this with the resources available.
And thank you, Delegate. And isn't it true that this will inform and enable childcare providers to access healthcare on our healthcare exchange? And in many cases, they may be eligible for reduced premiums just by virtue of their financial eligibility.
I couldn't have said it any better than myself, Madam Chair. Correct.
Just want to make sure everyone understands what we're doing. Delegate Shalega?
Thank you. Delegate Solomon, you went fast on the 250,000,000. Can you go back and repeat that, please?
Yeah, so we have gotten agreement from all the parties involved, including the governor's team, to take 250. So the governor added in his budget $2 million for a capital revolving loan fund for childcare providers. That is something we established in our package of childcare bills in 2022, and that fund has about 15 million, give or take, in it, maybe a little bit more. And so the governor, in his proposals this year, added an additional pot of money to that program. So we're taking a small portion of that additional 2 million, and we're now using it specifically for childcare access to health insurance for childcare providers.
In this bill?
In this bill. Well, it's in the budget. The language that's going to go with the budget is contingent on this bill passing.
So how much money and how are you distributing that to childcare providers?
So it's going to the Maryland Health Benefit Exchange to provide outreach services and supports and to do the survey that we've asked them to do. So they have obviously limited resources at the Benefits Exchange to sort of target certain populations. And so this way they will be able to do a much more robust enrollment campaign for childcare providers around the state to help them understand how the process works. This is not paying for their premiums. That's obviously significantly more expensive. It is just for the Maryland Health Benefits Exchange to conduct a much more robust outreach and engagement campaign with providers across the state, with a specific emphasis on providers that take childcare scholarship, but for all providers.
And so how much is the Health Benefit Exchange getting to do this promotion?
$250,000. And they have agreed that they can do this work for that amount of money.
Well, I'm sure they can. All right. Thank you.
Okay, do I have a motion on the amendments?
Move. So move.
Okay, do I have a second on the amendments?
Second.
All right, I've got a motion and a second on the sponsors amendments. Any discussion on these amendments? Then those in favor of the amendments, please say aye.
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 Any opposition to the amendments? Okay, seeing no one, can I get a motion on the bill as amended?
Move the bills amended.
Second. Got a motion on the bill as amended. Any discussion or questions on this? Bill is amended, seeing none. Those in favor, please say aye.
Aye.
Those opposed, please raise your virtual hands. Seeing no hands go up. Okay, thank you. Oh, okay, never mind. Sorry. I've got Delegate Shalega, Delegate Kipke, and Delegate Morgan. Okay.
Madam Chair, I'd just like to say
Yep.
I'm supportive of childcare providers getting services, but $250,000, why not give that to reach out to realtors or, other groups? So it's not because of childcare providers, it's a fiscal issue. Thank you.
Oh, I appreciate that. Thank you, Delegate. Okay, that bill passes.
Thank you, Madam
and
Chair.
Thank you, Delegate Solomon. You can go back to your committee now. All right, I would like to go to House Bill 830. Is Delegate Jones on? I see Delegate Jones' staff is on. Is she going to be joining us?
I will be here on her behalf.
Okay, great. So Lisa, you want to explain the bill and the amendment that was offered, that came with the packet today?
So the bill requires carriers to provide coverage for genetic testing to identify whether an individual with a personal or family history of cancer has an inherited mutation associated with an increased risk of cancer. The bill also, as introduced, would require carriers to cover follow-up evidence-based cancer imaging if the genetic testing determines the individual to be at increased risk of developing cancer, and prohibits a carrier from imposing a copayment, coinsurance, or deductible on coverage for genetic testing and follow-up evidence-based cancer imaging, with the exception of high deductible plans. The amendments that were distributed today would strike the provisions that prohibit the cost sharing. So the carriers would be allowed to charge a copay or coinsurance.
They would still be mandated to perform the test, to pay for the test, but with the cost sharing piece. Okay. That was an amendment that came out of our discussion yesterday. I know that Delegate Jones has another proposal, so I guess I'd like to discuss this proposal. And we have a hard stop at 3 o'clock, and we have a lot of bills. So if this discussion is going to go long, we're gonna, if it takes more than 10 minutes, we're gonna stop and then know that we'll be talking about it again tomorrow. So, Angelica, are you going to speak to Delegate Jones's suggestion?
Madam Chair, just real quick.
Josh? Okay.
I apologize. Just first and foremost, on behalf of the delegate, I want to thank you and committee staff and everyone here yesterday for discussing the bill and working through it. She really appreciates that. And now, if you would allow, I'd like to turn to Angelica to explain their position on it and what another option they feel like there may be.
Okay. All right. Thank you. Angelica?
Thank you, Madam Chair, and thank you, Josh. Yeah, so to Delegate Jones's proposal, I think if we wanted to make this bill more affordable, which I know was a concern by the committee yesterday, we could push for that language change, but removing the cost share would undermine the entire intent of the bill. It would not make any changes, and the barrier that patients face when deciding if they should get these tests recommended by their provider would still be an issue. So if there was a concession to be made, it would be, I would suggest to eliminate the evidence-based screening as opposed to the cost share. I also just wanted to note too that I know yesterday the primary conversation was regarding the cost, and I feel that we were also focusing on the higher end of what the MHCC study range was, but on the lower end, it was 2 cents per member per year, or 0 to 0.06% for an impact to the premium. So just wanted to also be mindful that that is a small price to pay for peace of mind, and knowing that what your cancer risks are. It helps put patients in the driver's seat of taking their own healthcare into their own hands. But yes, like to your question, if there was a concession to be made, we would be okay with Delegate Jones's language.
And I want to be clear what Delegate Jones is suggesting. So I have to get back to my. Okay, she's suggesting maintain the prohibition on the cost sharing for genetic testing, but allow for the cost sharing on evidence-based screening. So that's what is being discussed. We don't have any motions on the floor right now. Lisa Peabody? Lisa Peabody?
Hi, yeah, I wanted to address the no cost sharing supplemental screening. And, we think about screening could be a colonoscopy, which is thousands of dollars to a patient. And if you do have this mutation for a high risk colonoscopy, you could be high risk of colorectal cancer. You could be at an 80% risk of contracting colorectal cancer. And these screenings, national guidelines recommend you start screening at age 25. And this is thousands of dollars out of pocket for a patient. Often the insurance will apply those costs of a colonoscopy to a high deductible plan. And the patient pays thousands of dollars every year because that's what the recommended screening is. And what you're doing is you're taxing this group of people who are at the highest risk of cancer and not allowing them the screening and access that they need. So I would appreciate the cost sharing being added back, the no cost sharing being back added to that supplemental screening.
Okay. I'm going to go to Matt Celentano.
Thank you, Madam Chair. So I think we are certainly supportive of the amendments in the reprint that Ms. Simpson sent out to everyone. I think that it does mitigate the cost impact, which we are certainly concerned about. I just do want to correct, though, that proponents just said it was 2 cents per member per year. Now it's 2 cents per member per month on the low end. It's 17% or 17 cents per member per month in the mid-range, which is what the Maryland Healthcare Commission suggested is most likely. And the high end is 53 cents per member per month, which is a lot. And as I said yesterday, and I'll repeat here, the carriers are comfortable generally when there's, a per member per month mandate that is roughly in the 5 cent territory. We have 50 mandates in Maryland. Mandated benefits. It is more than pretty much every state. As one mandate, it's not a big deal, but the collective nature of 50 mandates makes carriers uncomfortable because those 50 mandates lead to increased costs that directly gets impacted to consumers. It is directly passed through to the overall risk pool. It is concerning, and when we talk about affordability, what we're talking about is access. And every time we pass one of these mandates, we have to balance what it means to the access that is affordability. And at a time when we have many, many Marylanders that are federal employees that are losing their employment and having to go to the exchange and other places to search for health care for the first time, it is super important that we remain and have an affordable product for them to make sure that they're covered, which benefits everybody, obviously. So we were concerned about the cost. And we think that if you allow carriers to have cost sharing, which is the way that we can use premium to keep the premiums low, but also have minimal impact to the consumers, it is going to take away a lot of these cost concerns. Now, we still think that the mandate of the testing is also problematic. We don't think that these are effective measures that should be utilized, especially when doctors, if you have family history, are going to order you for another set of testing. So it's duplicative in a lot of ways. But if we allow co-insurance, co-pays to add toward the deductible, we allow some sort of cost sharing, it takes away a little bit of our concern. And we're not talking about, these are very expensive tests, but the co-pay and the co-insurance on these tests for a consumer is very small compared to the thousands and thousands of dollars that the tests are, and can be even more depending on how deep you get in. So we think it is a very minimal ask to counteract and counterbalance the tremendous costs that come along with the mandated testing. Thank you very much.
Thank you, Matt. Deborah Coleman?
Good afternoon. I wanted to return to a point that the opposition just made regarding genetics testing being duplicative, and he has indicated that multiple times. And I would just ask him to clarify duplicative of what, because to my knowledge, there are no additional tests that will yield the same results or provide the same information as genetic testing, but I invite him to clarify what exactly he is referring to so that we can understand what he is relaying in terms of genetic testing being duplicative. Thank you.
Okay, so let me explain what's going to happen. Matt Celentano is going to respond to that question, and then I'm going to let my Lisa Simpson. Is your hand up, Lisa? Yes. No? Okay. Never mind. Then I'm going to let Lisa Peabody speak, and then we're going to stop this discussion and see if it can be worked out in the next 24 hours, and go from there. So Matt, please respond to Deborah's question.
Sure, Madam Chair. I didn't know we were fielding questions for each other, but I will say, when you have a marker associated with one of these tests as a comeback, it is immediately going to lead to more traditional lab testing that is going on from the physician order. So you might find that there's a marker here that exists in the testing, which you already would have found by traditional testing methods that the doctor would have ordered if you had a family history. So in most of the cases when these tests are going through, and what the MHCC said is it leads to duplicative testing and adds more cost to the system. That's what we want to prevent.
Okay. Thank you for that. Lisa, you're going to get the last word for today. Here we go.
All right. Yay. I got it last time too. So the reason that it's not duplicative testing is because right now the federal mandate says that only BRCA1 and BRCA2 is required at no cost sharing. And what we're hoping, what the intent of this bill is to modernize what is recommended is that a multi-panel test for many genes. So a doctor isn't going to recommend that a person who had let me backtrack, let me explain this better. Every person who has a family history of hereditary cancer is not going to be getting multi-cancer gene, this multi-gene panel. They're going to get smaller panels, but there's also circumstances where a patient who might have Lynch syndrome has a family history of colorectal cancer. And the only way you're going to find that is to go further than just BRCA, because BRCA is not associated with a high risk of colorectal cancer. If that makes sense. So it's not duplicative, it's in addition. And it's not every single test that every single patient who comes in and needs genetic testing. They're going to be evaluated by the family risk. The reason they're going to have BRCA testing, or they're going to have multi-gene panel, if that makes sense.
So I'm going to break my own rule. I'm going to ask Matt a question. Matt, if there's a family history of cancer, what would a primary doctor do with that knowledge?
Madam Chair, I'm hesitant to answer that question because I am not a physician.
Because you're not a doctor.
Yeah,
Okay.
and I don't have a line of sight to exactly their protocol. I can ask for sure for you.
Okay, so
I have some experience with that.
Oh,
sure.
Wait a minute. Who is that?
Lisa again.
Oh, what? Okay.
So if you're in with your physician and they do see a family history, ideally they're going to send you to a genetic counselor who's trained to look at your family history, all the different types of cancer, and recommend the appropriate test, whether it be BRCA or multi-gene. Sometimes the physician looks at the family history and feels that they have the knowledge and experience to recommend a test. And so they would be the ones who would suggest which type of test.
So Madam Chair, but once again, we have sort of conceded the point on the mandate for the test. We just want to be able to retain cost share to be able to mitigate the cost impact, which is, I think, a small thing to ask.
Okay. Okay, thank you. Thank you both. And sorry, Angelica, I've got to stop because we do have a number of bills on the agenda. So we'll see what we can do between now and tomorrow. Is Delegate Wells on? Bridget, do you see Delegate Wells?
I do not,
Okay, we're
but
gonna,
she had said that Patrick and Lindsay could
Oh.
take this on.
okay. All right, well then I'm gonna actually skip 1007 because I know Patrick is here and that I think is gonna be a little bit longer discussion.
I will say Hutchinson is here though too.
Okay. And I don't have his bill on my list.
He's here on a one.
Oh, I see. Delegate Hutchinson, you're on for House Bill 1351, right?
That's correct, Madam Chair.
Oh, I'm sorry.
We have to hold that because we don't have the amendments.
Yeah, exactly. We just
Okay.
got them sent over. We did have a good work group this morning. I just got them, but if we could hold that and bring that up tomorrow, that would be perfect.
Madam Chair, I want to apologize so much on behalf of the carriers. There was a technological issue. There was a hit send. It just didn't get out, but I just texted Delegate Hutchinson pictures of the amendments. They are done, and I think we're all in agreement, but you don't have the email, and we're really sorry about it.
Okay, so your apology is accepted, and we will take this up tomorrow, and hopefully it'll be one of those kumbaya moments.
It should be easy, Madam Chair.
I think that's what I'm hoping for. Then we will go to House Bill 1087, health insurance step therapy or fail first protocols, drugs to treat associated conditions of advanced metastatic cancer. That's Delegate Bandari. And Lisa, we have not talked about this bill before, so tell us about the bill.
The bill prohibits carriers from imposing you said 1087, correct?
Yes, I did.
Okay, sorry. From imposing a step therapy or fail first protocol for a prescription drug approved by FDA that is used to treat a symptom or side effect of stage 4 advanced metastatic cancer as specified. The amendments that have been distributed provide that the drug must be prescribed and covered under the terms of the policy or contract.
Okay. Delegate Bandari, you want to speak to your amendments and your bill, please?
Yeah, thank you so much. I think it's pretty much workout bill. We accepted MIA's amendment, and Coleman also agreed to ensure requested clarification regarding treatment consistency and peer-reviewed literature. The insurer final amendment remain kind of unresolved. Here is a Patrick Hogan. You want to say, Patrick, are you here?
Yes, he's here. Patrick, do you want to speak to any unresolved issues?
Sure. Thank you, Madam Chair. And Angelica is still here on this bill as well. Yeah, I think what Delegate Bandari has put forward, the MIA amendments, and there was a portion of the amendments from the carriers, but I think there was one section where the carriers put forward, it said that the prohibition shall not apply where step therapy or fail first protocols promote the use of biosimilars or generics, provided that such use is consistent with best practices for treatment of the condition and does not negatively impact the insured or enrollee's health. And so Komen does object to that amendment that was put forth. The way they read it, it just seems like that just allows them to still do step therapy and again continues to potentially delay. These are patients who are, advanced stage and can't afford a delay with language like that. So that's the concern that Komen has. But as we said, we did accept the other amendments that had been proposed, and I'll stop there. Angelica may have additional comments, but that's where we are on it.
Okay, thank you. Matt Celentano, can you explain that sentence to us?
I sure can.
Thank you.
But I would like to sort of level set first too. This is a first year introduction. We have not seen this bill in the past. And usually with these types of bills, they get sent to the MHCC for actuarial value and study. There is some data around it, but we don't have full data. So we do not know the cost impact of this kind of bill. That being said, we thought that this was certainly a measure that was worth working on before the benefit of an MHC study. We would like to see full impact, but because, like we heard in the last bill, and we're going to probably talk about on more and more bills, we are extremely concerned about cost impact of some of these pieces of legislation. And what we tried to do in this amendment, which we still think we're surprised that it was not accepted, is that, and we wrote it specifically to make sure that we thought that the intent was still met, that the prohibition for STEP would not apply to biosimilars and generics, provided that such use is consistent with best practices for treatment, still up to the doctor. If they want to go to the other drug, that's fine, and does not negatively impact the insured or enrollee's health. If they want to go to the other drug, that is fine too. But there are a lot of drugs out there, and a lot of these cancer drugs are really, really expensive, as this committee knows very well. And we do believe that it is important, sort of like the accumulator bill, where we talked about it's fine if you want to use a brand name drug, but we would like you to use a biosimilar or generic equivalent if there is one available. And because the drugs in the cancer space are so incredibly expensive and without the benefit of an MHCC study, we would like, if there is a replacement of a biosimilar to a generic to a brand name drug, to go there first. It's not getting out of the STEP therapy. It's not trying to circumvent STEP therapy or the prohibition of STEP therapy here. It's to make sure that if a lower cost drug is available and just as medically effective, that it's utilized. And that's it. Thank you, Madam Chair.
Thank you. Angelica.
First, I just want to thank you again, Madam Chair, and the the dialogue that we have today. Just based off of what Matt had explained, that to my understanding is STEP therapy, allowing a patient to fail a drug that their physician did not prescribe first so that they can get approval is STEP therapy. So as Patrick had mentioned, these are metastatic patients. Time is of the essence. Their treatment is highly personalized and targeted, and they just cannot afford to have the wait and see approach with a generic or biosimilar. Matt had also mentioned that they're not changing the idea that a provider cannot, that a provider can still prescribe you the medication. So but that's not in the language that was suggested. So I would say that we need to include that. Additionally, this bill would also prohibit the associated conditions, which can include patients, white blood cell counts, severe pain, fatigue, lymphedema, severe nausea, vomiting. So these are just the conditions that are, sort of the side effects from their cancer treatment. So if somebody has debilitating, nausea or vomiting, you can't apply the wait and see approach. And we actually had a metastatic cancer patient who had those symptoms, and then she had to be admitted to the ER. And then, if you want to look at this from a cost savings perspective, she had to be admitted to the ER, her stay in the hospital, the additional treatment she needed, all were much more costly than just having had treated her symptoms in the first place. So, that's where we stand on this. We do suggest to continue the bill with the amendments that are currently in there. Also, I do want to add to that this similar bill has passed with associated conditions in states such as Arkansas, Delaware, Minnesota, Mississippi, Louisiana, Oklahoma, Ohio, and Texas. So those are some examples of other states that already have STEP therapy, already have prohibited STEP therapy for metastatic cancer patients with associated conditions.
Okay, Matt, you have
Yeah, Madam Chair, I just want to make sure that there's some clarity here. Nobody's suggesting, first of all, we don't use fail. We don't want any patient to fail, nor are we suggesting that somebody fails on another drug or it finds that it didn't work for them and then we go to another drug. We just want to make sure that the same effective drug that is in a different class that is much cheaper is utilized in the first place. The other thing I just want to correct for a lot of people, there's a lot of discussion around delays in healthcare here. And this body was wise enough to pass a incredibly impactful prior auth bill last year that changed the timeframes on all these drugs and when the carriers have to approve them. But for the benefit, even without that discussion, the average approval time of these drugs is 27 minutes. The longest ones are usually in the 2-hour time frame. We're not talking about a significant delay. And we're talking about drugs that could be in the thousands and thousands and thousands of dollars. And some of the biosimilars and the generics can be in the $5, $10, $15. So for the overall cost to the system, we think it's probably a worthwhile solution to have. And the amendment, I think, addresses that without circumventing the ban on step therapy, if we want to label it that.
Okay. Patrick Hogan?
Thank you, Madam Chair. I'll be very brief. I know Matt and I exchanged messages earlier today, so we'll try to connect and see if we can come to agreement on language, talk this through some more, get a better understanding, and get back to the subcommittee.
Okay, then we'll hold this one. Thank you. Thank you for that. Thank you for being willing to work on it. I'm going to go to House Bill 1292, Health Insurance Provider Directory Required Updates. Delegate Kaiser. Lisa, what's it do?
Thank you, Madam Chair. I'll begin with a simple explanation.
Okay.
This bill is aligning code with updated federal standards on giving updated information on directories, as described during the hearing, that people are given old information and they're supposed to be giving updated information. Just let you know that it's making it easier to get the more accurate information online. We worked with the administration and we worked with industry that I believe supports these amendments, though I believe Mr. Celentano has another amendment that we then, because I think is sent over the reprint and then the other amendment that he can explain better. But I also know that Lisa will explain this as well. But this is really just about giving people better information that they need.
Okay, Lisa, do you want to talk to us about the bill and the amendments?
I actually think Delegate Kaiser did a pretty good job, and I am having trouble finding the amendments in my folder at the moment. So
Okay.
I apologize.
I'll move the amendment.
Okay, I've got a motion on the amendment. And do I have a second? Okay. Discussion on the amendments. I have Dan Darty.
Is this like dating, like Tinder for?
Oh my.
Delegate Tavares, you're not on mute.
Oh, sorry. Sorry about that.
Mr. Darty.
Thank you, Madam Chair.
Go on, Denny, tell us more.
Yes.
I'm addressing the amendment that Delegate Kaiser referred to that was received shortly before the subcommittee was meeting. And what in essence it does with dental plans, it changes.
I don't think we're on that one yet, Mr. Doherty.
Okay.
I think we have to, we haven't even mentioned that we have that one yet.
Right, we're just doing the
first
original.
amendment. Yeah.
I apologize.
Okay. All right, so I've got a motion on the original amendment and a second. Any discussion on that amendment? Seeing none, those in favor, please say aye.
Aye.
Any opposition? Okay, that amendment passes unanimously. And now what's the second amendment, Delegate Kaiser?
It's there's a dental exception that I think Mr. Doherty is going to explain why dentists should be excluded from one part of the provision.
Okay, Mr. Doherty.
Thank you, Madam Chair. What this amendment does, when the bill was introduced, the provider listings had to apply to all equally. Without this bill, it would have remained with 15 working days. And what this does is it carves out dental plans from the requirement of doing it within 2 working days. Dentistry is one of those professions where if you don't have a dentist, you're usually looking for one when you're in pain and you may have an infection. And waiting 15 days for updates online is, in our opinion, inappropriate. There's no reason to distinguish why a dental provider's directory shouldn't be updated versus a medical director. So we would be opposed to this amendment.
Okay, I don't have the amendment in front of me, so I'm sorry. You're opposed to the amendment that takes the dental providers out?
What it does is the bill is introduced, all provider directories had to be updated within 2 working days for online.
Oh, so it's
It
the time.
included dental plans. This takes dental providers and puts them back under the law that we're amending. And we don't think that it's justified, and we think it's also a profession where people need to be able to access quickly dentists that are available, because if they're in pain or have an infection, they need treatment promptly.
Oh, I see. I'm sorry, I was a little slow on the uptake. That was me, not you. I'm going to go to Delegate Taveras and then to Matt Chilentano.
I'm just gonna put it out there. I mean, I'm fine with this bill, but is there a way that we could rate these providers?
It's another bill, Delegate.
All right,
Let's
next
talk
year.
about that later.
Next year.
Okay, next
All
year.
right.
Matt Chilentano, you're responding to the
Yeah, I would be happy to, Madam Chair. Thank you for the opportunity. This bill, and I'll take the discussion back to the hearing. And one of the reasons why the carriers are opposed to the bill as introduced, and I want to thank Delegate Kaiser so much for working with us, and Commissioner Grant for understanding that this is a work in progress and we need to continue to work on this, and we will through the interim. But the bill that was introduced, we're challenged by, because there's the only skin in the game, so to say, is on the carrier, right? And carriers are required under the original bill to contact the providers and have them and update their information. They don't respond. And that's our fundamental problem with this bill. And I was told the feedback I got from the carriers was it takes between 10 to 15 times of outreach for them to respond and to get impact, or to get updated contact information. If you look at the Maryland universe, there's probably about 15,000 providers, and that's just in the health space. You take 15,000 providers times 15 times 6 commercial carriers, you get to about 1.35 million amount of times it takes. The bill wanted us to do that every day to verify that. It's a tremendous lift, and without the providers having skin in the game, it's something we're going to fail on. But also, the bill is based on the No Surprises Act and the No Surprises Act at the federal level. The No Surprises Act, and the reason why the Dental Plan Organization Amendment is here, is that the No Surprises Act didn't include dental carriers. It's just health carriers. Dental plans are fundamentally different than your health insurance providers. They're not as large organizations. They don't have as robust IT and or administrative staffs like some of your traditional health providers. So this bill is a baby step to getting us to where we need to be, and it's focused in the health space. And because of that reason, we wanted to leave dental out until we get to that portion of the conversation, and those dental carriers would operate still under existing Maryland law. So that's the explanation of the amendment. Thank you, Delegate Collison.
Thank you. Dana Kaufman, please.
Sure. I keep freezing. MedChi supports the bill as amended, the first amendments, but I do want to add, because Mr. Celentano brought it up, for as much as the insurers may be frustrated, the providers are equally frustrated, because I hear reports that they send updated provider direct information over and over again, and it does not get updated. So I do think this is a situation that we can work on during the interim as well.
Okay.
Thank you, Ms. Kaufman. I'd be happy to work with you on it.
Yeah, you guys got to start talking to each other again.
We do.
Delegate Kaiser, where are you on this amendment?
I am fine with the amendment, and I'd like to move it.
Okay. Do I have a second? Do I have a second?
Second.
Okay. Okay, I have a motion and a second on the second amendment. Any further discussion on the Second Amendment?
Madam Chair, could I add something else? I'm sorry.
Oh, sure.
Uh,
Go ahead, Delegate.
You know, with so many things that we do here in the General Assembly, you know, we sometimes take baby steps or we try something out. And Mr. Celentano, to me, has made enough of a case to explain why the dentists are different. I mean, we always have next year, and we always have a chance to deal with both what he said and what Ms. Kaufman said about, you know, are the providers sending the information repeatedly? Are the insurers asking for it repeatedly? You know, what's the problem? What's the disconnect? And similarly, what more can we do with dentists to make this happen? But again, we are aligning things with federal standards, and the dentists weren't in those federal standards. So I think a case has been made, but there's always next year. And I think we can maybe take a look then of if there's a way to speed that up for dentists as well.
Okay, thank you. Thank you for that explanation. So I have a motion and a second. Those in favor of the Second Amendment, please say aye.
Aye.
Any opposition to that amendment? You don't get to vote against, Mr. Doherty. Seeing none, the Second Amendment is unanimous. Can I have a motion on the bill as amended?
Move the bill.
Second.
Okay, a motion and a second on the bill. Is there any further discussion on the bill as amended? Seeing none, those in favor, please say aye.
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 Any opposition? Seeing no hands, the bill passes unanimously. It is 2:55 and we are going to hearings in 5 minutes, so we will need to adjourn for today. Please watch the schedule. We will take up the remaining bills and the ones that we held today tomorrow. Thank you all very much, and thanks for your patience and your work together. I appreciate all of your work. Thank you.
Thank you.
Fine. Thank you.